Hey people, welcome in. Deeb here, host of the RxPOSED podcast, episode 5 with Jen Adams. We have a really interesting discussion about the dissonance in pharmacy education and the scope of practice and what's allowed within each state from a regulatory and legislative perspective. Jen also talks about payment for pharmacist services and how we are facing challenges with getting paid for services that we can provide. In addition, we talk about colleges of pharmacy, the trends within admissions, graduation, and tuition, and she gives you a forecast of what she believes is going to be happening within the next few years. Is there truly a shortage now or coming in the future of pharmacists? She also talks about standard of care versus bright line rules. What's the difference between the two? And what are the pros and cons of each? And how has that led to some independent prescribing allowances and opened up those allowances within the state of Idaho? Thank you so much for your support and listening. Let's get into it.
Welcome to the RxPOSED podcast with your host, DB.
Jen, welcome into the RxPOSED podcast. I'm super excited to have you on today, coming in all the way from the great state of Idaho. I really appreciate you being on and look forward to chatting with you. I know we have some really interesting and important topics to talk about today, but for our guests who don't know who you are, tell them about yourself and tell them who Jen Adams is and why they should be listening today.
Well, Deep, thank you for having me. I'm excited to be here, so I appreciate the invitation. So my name is Jen Adams, and I have a couple of different hats that I wear. I'm an associate professor at Idaho State University, and so I teach and I do research and all of those sorts of things. And I'm also the associate dean for academic affairs at Idaho State. In my teaching, I teach healthcare systems, and I teach pharmacy law to both pharmacy students as well as clinical psychopharmacology students. So these are psychologists that are learning how to prescribe. So a lot about law, a lot about regulations, and sort of how that impacts the practice of pharmacy and how to not break the law. So that's good, right?
Yeah, definitely. That's super important. And Jen, you've had quite a interesting background too with some of the things that you've been involved in with your career. So can you tell us also a little bit about some of the groups, associations, and things that you've worked for and done work with in the past?
Yeah, when I talk to students about careers, I often will say there's so many things you can do with a PharmD degree that I had no idea when I started pharmacy school. So my first job out of pharmacy school, I worked at the American Pharmacists Association. I worked with all the student chapters. I oversaw all the student educational programming at the mid-year regional meetings and the APHA annual meeting. Also did a ton of student leadership development, oversaw all of the patient care projects and the National Patient Counseling Competition. So had a great time working there with the folks in student development, and then got recruited to work with the board of directors and the House of Delegates and to have kind of a different role at APHA. And while I enjoyed that role, I also figured out from that role that part of the reason I loved my job at APHA was because I got to interact a lot with students and with faculty, chapter advisors, often deans, associate deans at the colleges. So it was kind of a big eye-opener for me that part of the reason I loved my job wasn't just because I worked at an association, but it was a lot more about academia. And so there was an opportunity that came up to move over and work at the American Association of Colleges of Pharmacy. I called the CEO the same day that somebody that was their top pick had turned them down for the position. So got lucky that it was still available, and ended up working there for about 10 years, working predominantly with deans and associate deans at the colleges, a little bit with faculty, but mostly with deans and associate deans. And while I was there, I was able to earn my doctorate in education that's focused in higher ed administration, which helped me in my job there, but also was part of what led me back in academia to working for just one pharmacy school instead of all of them. And I have been at Idaho State now for this is my 7th academic year, so 6.5, almost 7 years. At Idaho State, which is nice because I'm an Idaho girl, born and raised, and went to Boise State for undergrad, ISU for pharmacy school. And so it's really nice to be able to take the experience that I've had at the national level and be able to bring some of that back to my alma mater here at Idaho State.
Yeah, so I mean, right off the bat, it sounds like you've had some extensive experience on the national level, and not only for one association, but really working, various in two different associations. And as you mentioned, it is really interesting how that kind of came back, full scale of you starting out in Idaho and then traveling outside of Idaho, then coming back to Idaho to now be at the College of Pharmacy. So I think that just hearing you talk about the experiences that you've gained must just, I think for people out there listening, it's a must that, to hear your perspective on some of the topics we're going to talk about today is really important. And that's why I'm so excited that you decided to join us for the podcast today. So thanks for sharing your background, and hopefully people will really understand, where you're coming from too with some of the perspectives that you have. So to shift gears just a little bit, obviously there's a lot of things that have been going on in the past few years, especially with COVID, 2020, all the stuff that was happening in these last few years with the profession of pharmacy. There's a lot of challenges that we're seeing and a lot of opportunities. So I'd be curious to hear what you think are the two most pressing challenges that we have in the profession of pharmacy. And I'm going to challenge you, Jen, to not only name those challenges, but what are some innovative solutions that you would suggest to those challenges? Because in this podcast, we don't just want to talk about the problems. We want to talk about the solutions, of course.
Yeah, I'd be happy to comment my feelings about that. I mean, obviously, there are folks who are probably going to disagree with me on what I think our two most pressing challenges are. But hopefully, I'll give a little perspective and folks will be open-minded and be able to, hear me out. So, number one, I think, is that in pharmacy, our scope of practice does not align as well with our education and training as it should. So there's always the goal of an education program, right? Like a PharmD program. The goal is to train somebody, not just exactly for what practice is like at this moment in this minute, but for what they, envision it to look like in the next, say, 5 years. So with that, there's some cognitive dissonance that happens there, right? You come out and you're like, well, practice isn't like they told me it was going to be. And there should be some dissonance there if we're really training people to be kind of in that like 5-year window. But I think in some ways in pharmacy education, we've gotten a little bit farther even beyond that. And so there's folks who are graduating that are feeling like, wow, I have this fantastic clinical ability that I gained when I was in pharmacy school, and practice doesn't align with what I'm learning. Like what I'm seeing as a new practitioner does not align with what I was taught pharmacy is supposed to be, right? So scope of practice is, I think, probably the number one most pressing challenge, that we need to align our scope of practice nationally better with the training that our graduates have been receiving. Now, there's some states that scope of practice is great and they have really great independent authority to do a lot of things as pharmacists. And so that's also contributes to this challenge, right? So if you've got one state that's kind of a little bit more out front and then other states that are lagging really far behind, I have to train students to practice at the most innovative, most advanced state, no matter where I am. Because somebody could graduate from my program and move to another state, I've got to be sure that they're ready and prepared for that. So that's a challenge on the education side. And so we've been trying to do that. But when states don't have similar scope of practice, which I say all the time, if you've seen one state, you've seen one state when it comes to pharmacist scope of practice. But if states are not keeping pace with each other in terms of what they're allowing pharmacists to do, that dissonance of, my clinical ability that I come out of pharmacy school with versus what I'm allowed to do based on what my license allows, when those don't line up, that's when we have people that get very dissatisfied with our profession. They are frustrated. I think some of this is also what leads to some of the workplace conditions and things that people talk about. And I think that in itself is one of the things that reduces job satisfaction for our graduates and for pharmacists who are supposed to be able to be out there serving their communities in the way that they've been trained. So that's number one.
That's a big one. That's a really big one.
It's a big one, and it's complicated, and it involves a lot of other things. And then number two is we have got to make sure that pharmacists can get paid for their services and not just for dispensing a product. And I feel like I'm kind of beating a dead horse with this one, because I think, the pharmacy profession's been talking about this for more than 20 years, right? That we've been tied to a product, tied to dispensing, and that if we don't have that component to what we're doing, we can't get paid for our services and for our care. And there has been some advancement in this space, but there's still work to be done at the national level and still in a lot of states. So we've got to be able to get paid. We've got to be able to build a medical benefit, not just the pharmacy benefit. So again, a big, complex problem. Pharmacists have to embrace a whole new revenue model, right? Right now in a community pharmacy, if you bill a prescription, adjudicate a prescription, you get paid right then. Now, I'm not going to get way into the weeds of PBMs and clawbacks and all the things that can happen, but you do get paid right then. If you're providing a service and you're billing a medical benefit, you might not get paid for 30, 60, sometimes even up to 90 days. And so that's a different business model. And until we can prove that business model of billing a medical benefit is sustainable in various different pharmacy practice settings, we aren't going to see a huge amount of uptake, even if we change the laws to allow pharmacists to be providers at the state level or at the federal level. We have to be able to demonstrate that this is a viable business model, not just that it saves the healthcare system money, not that it's the best thing for patients, but we really have to have this three-pronged approach where it's sustainable for pharmacists and pharmacies and clinics and health systems and everybody across the setting spectrum, that getting paid for services on the medical benefit, getting paid for services and not a product, is sustainable.
Thank you so much for listening to the RxPOSED podcast. Liking, subscribing, commenting, or sharing means the world to me, and I really appreciate it. Back to the episode. Yeah, those are really, really good parts that you brought up to both of those, which are very complex. But it sounds like, too, from what you're describing, that both of those problems are actually linked, and probably linked a lot more than people would think about initially, right? So you have the differences in scope of practice. You have people in various states and colleges of pharmacy and the laws and rules and what you're allowed to do in some states versus others. And then you have on this other end being paid for services, which can be linked directly right back to that scope of practice, which seems like just a giant puzzle that we're trying to solve. And so I'm curious to hear some of the solutions. I think that based on a couple other questions that I'm going to ask you, maybe we will get into the solutions, so we don't have to we don't have to spoil what those are. But I really appreciate those two being your most pressing challenges. And I will say, I love asking this question because you get a different answer from anyone that you ask, but in some way, shape, or form, a lot of the answers that I've been receiving are pretty connected in a weird way. So it all kind of comes back full circle. I do want to ask you, about colleges of pharmacy, because obviously this is one area that you're an expert in. You've been in this space, you've worked on the national level, and I think that you just have a ton of insight, and it's definitely part of the puzzle, I believe, that you're talking about. So when we just take a snapshot and look at, maybe the last 2 decades of schools and colleges of pharmacy, the number of schools and colleges of pharmacy have doubled in how many are accredited and available within the country. The tuition averages have climbed to, I think I saw more recently, it was about an average of like $150,000 for tuition. It usually goes between that and like 170,000 is what I've seen in the past few years. And there's a big problem with the number of applicants and the number of seats. The number of applicants, the people who are applying to colleges is gone down, especially with colleges of pharmacy. The number of seats that colleges are trying to fill has continued to go down over the last 10 years. So I'd be curious for you to tell us your thoughts on the challenges and the opportunities that colleges of pharmacy play within kind of the bigger overarching profession, and what is your forecast for the future of education, knowing that there's a lot of these things that have been occurring over the past 2 decades with colleges of pharmacy?
Yeah, so again, another big complex problem, right? And so thinking about the challenges and opportunities that exist, obviously the challenges for colleges of pharmacy, it's a pendulum, right? Like interest in pharmacy has been a pendulum for years and years, that we have a ton of interest and then that interest dwindles. And there's a lot of things that impact that. So it can be salaries, it can be public perception of what it means to be a pharmacist is a part of that. Social media has played a huge role in that. In, I would say, the last 15 to 20 years, the angry pharmacist didn't exist 20 years ago to talk about how difficult it is to do this job, right? So social media, I think, has played a role in that. But at a college level, my budget is based off of how many students I'm bringing in, right? So that in itself is a challenge. And the opportunity that I think that exists within that challenge is that colleges are really taking a step back and saying, what's our core mission? Who do we want to educate? What is the type of student that we want to bring in that we know we can retain and can develop into this pharmacist that I know that our society needs, right? And what's realistic for how many students in each program that we can recruit that have that level of quality of what we need to be able to take. There needs to be a certain level of foundation for that student coming in for us to take and then mold them and help them develop the knowledge, attitudes, behaviors, skills that they need to be the kind of pharmacist that I want to take care of my family, my aging parents, that sort of thing. And so I think there's an opportunity in there for colleges to really take a step back and figure out what's the right size for my state. What's the right size for the workforce needs where I am? I'm at a state-based institution. I know that sometimes it's a little different if you're at a private institution and how you look at some of those things. But at least for those of us on the state-based institution side, we are serving our states. One of the things a lot of people don't know about Idaho State University is we train Idaho's and Alaska's pharmacists. We have a campus in Anchorage, Alaska, and then 2 campuses in Idaho, and we are the only pharmacy school in both of those states. And so we take that responsibility very seriously, and that is part of the opportunity that we're going to right size what we're doing to meet the needs of Alaska, to meet the needs of Idaho and the citizens of our states, because that's part of our fundamental core mission as a college. And we're going to develop them into those practitioners that have the knowledge, skills, and attitudes and behaviors, the professional identity that we want them to have as pharmacists. And so I know there's been a decline. I know there's looking at like the tuition and those sorts of things, and not to recruit for my institution, but we are one of the lowest cost colleges in the United States, in state and out of state. But I think that as colleges, we have a responsibility to take a step back and say what's needed, what's the right cost, how do we balance that with having the right faculty with the right expertise so that we maintain accreditation standards, right? You can't just say, well, we'll just get rid of half of our faculty. You've got to have the right folks with the right expertise to actually teach a PharmD program. So, and obviously our costs go up at colleges on what it takes to provide this type of education. If you think about our model, we have live synchronous education that happens in 3 locations, 2 time zones. It gets a little complicated. We have, production level equipment on our campuses to be able to provide our curriculum in that way. And there are costs associated with that equipment. So it's an important thing for us to be able to balance that with the cost of education. We're lucky that we are at what I would call a state-supported institution. We do get a decent amount of state-appropriated dollars to support what we do, and I know that that's not the place for everyone. And so that is a challenge for other institutions where they're not as state-supported as they could and should be, because when you're not state-supported, where does your revenue come from as a college? It comes from student tuition and fees. And that's really what keeps the doors open, right? Or the lights on, as they say, for sustainability. But balancing that cost of education is huge. You mentioned, average debt for students coming out. Sort of the rule of thumb in undergraduate education is whatever degree you're getting and the job that you're going to seek from that degree that you're going to get, bachelor's level. You don't want to have more in student loans than you'll make in your first year of salary. Well, pharmacy for years has been able to use that as our criteria to say, hey, people are going to come out and you're going to make more money than you're going to have in student loans. And that has changed. That rule of thumb, though, is for undergraduate education. It's not for professional level or graduate level programs. The rule of thumb there is a little bit different, that you are investing in your future. And that rule of thumb doesn't necessarily have to be exactly there. And so far, at least in pharmacy, we haven't gotten so far in terms of the average student loan debt. Like if you look at physicians, veterinarians, some of the other health professions, they come out with significantly more student debt than our students do. So, but it is something that's important to keep a pulse on, for sure.
Yeah, some really, really great points, and thank you so much for sharing the insight there. I mean, there's a lot to unpack with the topic. Of course, we could spend probably a couple hours talking about just this topic, but I am kind of curious. So, I'm not. Don't quote me on this, but I think there's another health profession out there, and maybe it's dentistry. I'd have to do some research to double check, but there is another health profession out there that I heard this more recently and thought this was pretty interesting. But I believe the way that they control the the number of individuals who enter into their profession is by some sort of a method where they have the state and then the number of allocated seats that the colleges within that state have for that profession. I think it's dentistry, if I'm not mistaken. What are your thoughts on our current model? Because I know that other health professions do things a little differently in terms of the number of seats, the number of people who are in the profession. And that doesn't mean that that's the right way to do it. Of course, we've seen, physician shortages and projections of that as well. So not that there's necessarily one right way to do it, but is there a different model that pharmacy could or should be looking at in terms of allowing, certain individuals to go into these programs?
Yeah, from my perspective, it's more about the quality of the applicant that's coming in. Even if it's, say 1-to-1, we have one applicant for every seat that we have. If they don't meet the level of quality and expectation that we would have in terms of their foundational learning coming to us, then we as an institution have to say, we're not going to accept everyone that, if you don't meet these criteria, we're not going to accept, even if we just have one applicant per seat or less than one applicant per seat. We have a certain level of quality that we have to maintain. And so I think that's one important piece. Do I think it should be dictated by, what the state projects per X number of people? How many, number of people, how many pharmacists do we have per number of citizens in the state? I don't know. I don't know that that's the right answer, because I don't know that that's going to encompass everything that you would need. And it might stifle innovation to put those kind of restrictions on states.
Yeah, and you're right. I mean, I don't know that there's necessarily one perfect way to do it. I guess it's really more so just examining what do other professions out there do, and how does that impact them. So I'd be kind of curious, just generally speaking, if there is a method or some sort of methodology. And then, another thing that you alluded to, and I'd be curious to hear your thoughts, because I've heard mixed things. Some individuals out there saying one thing, and maybe other groups or individuals out there saying the other thing. But based on the way that the data is trending for pharmacy school applicants, the number of people who graduate from pharmacy schools, do you believe that we're heading into a situation where there truly is a shortage, either currently or into the future, or there will be a shortage of the amount of pharmacists who are graduating compared to the amount that the workforce needs in terms of people to fill positions? What are your thoughts on that?
Yeah. So before I fully jump into that question, I'm going to answer the other part of your other question around the other models. So physicians, obviously, there's a very different model. They have to do a residency to become licensed as physicians, right? So when they look at the availability of graduate medical education, that dictates how many seats a program can have, right? Like big picture across the board, you cannot graduate more physicians than there are number of residency programs out there. Like podiatry, for example, one specialty area for physicians, they really limited the number of applicants, or not the number of applicants, but the number of seats at the programs, at podiatry programs across the country, because they would not allow it to exceed the number of podiatry residency positions. And so there are those kinds of pressures for physicians, but pharmacy is not there yet. We're still at this ballpark place where we have capacity for about a third of our graduates for residency programs. And there's still conflicting opinions on whether or not residency should be required for pharmacists, or whether or not, the accreditation standards say that we are preparing a practice-ready graduate. So if I'm preparing a practice-ready graduate, does everybody need to have a residency? And obviously there's various different opinions from the national associations on whether or not that's the case. But I think that's another important piece to consider. Now to go back to your question about the shortage, right? Like, is there going to be a shortage? So remember this pendulum, right? One of the things that impacts the pendulum is demand for positions, right? So if you're thinking about, like, I graduated from pharmacy school in the height of the shortage, right? So there were lots of moms and dads out there telling people, oh, there's a shortage of pharmacists. You're guaranteed to have a job when you graduate. You should go into this particular path. And I feel like the demand for positions is a major component to what has impacted that pendulum. And so we've seen less demand for pharmacy education. There's still a fair amount of demand for the number of people to fill those positions. People talked for a short period of time saying, we have too many pharmacists. The pharmacy schools have increased their enrollment too much. It's interesting because I think that the profession thinks that academic pharmacy is a battleship versus an aircraft carrier. We cannot turn on a dime. So For years it was, you need to give us more graduates, give us more graduates, give us more graduates. And then we did. And then it's like, oh, no, that's too many, right? And so again, that pendulum swung back. I do believe that it is beginning to swing back the other direction. And even if you look at, the monthly application statistics that the colleges get from PharmCast for this application cycle for our class that will start next fall, we're starting to see small upticks in the number of applicants. I think, of course, there's a right sizing that has to occur, but at the same time, I do think it will begin to tick back up.
I really like the example of the battleship and the jet, I believe is what you called it, or the airline.
The aircraft carrier.
Aircraft carrier, yeah, that's a really good visual for people. And I think so in summary, it kind of comes down to simple economics, right? Supply versus demand. And as we've seen within pharmacy and probably within other health professionals, I'm sure as well, there are trends. So it's at times we'll have more, at times we'll have less. We're kind of in a weird spot right now where, like you said, there was maybe a thought that there was too many individuals who were the pace, and then now all of a sudden it seems like, from what you're saying and some of the data that we're seeing, maybe we're on the other end. And so it'll be kind of interesting to see where we go from here in terms of what's next.
Well, and if we begin to solve the two most pressing challenges, there may be a lot more opportunities for pharmacists that didn't exist today, right? And so that can potentially change the demand as well.
Yeah, that's a really good point. And I think that can lead us into, some of the discussion of this next topic, which I think you're alluding to a little bit, and maybe we'll cover some of the solutions, I hope, of some of the challenges that you talked about previous. So just to give a little bit of background to this concept and the question, the concept of what's called standard of care versus bright line rules. I know that this is one that is near and dear to you. I know that you've done some research in this area. It's something that you all in Idaho have been leading the way in terms of, how to transition. But it is a hot topic, and it's an interesting topic that's being discussed on the national level and the state level on how can states approach pharmacy enforcement in terms of their law and rulemaking. So can you give people an idea of what exactly is the concept of standard care, and what would be the difference between standard of care versus bright line rules? And then in addition to that, what are the pros and cons of standard of care versus bright line rules? And then lastly, I think this kind of alludes to one of your solutions, is independent pharmacist prescribing. How does that play into standard of care?
Yeah, so I'm going to start with bright line because that's what most people are familiar with, because that's the model that almost all 50 states use to regulate their pharmacists. So right now there's only 2 states that don't use completely bright line rules or regulations to regulate pharmacists. And so bright line is that a law or a rule, so whether it's a statute or a rule or a regulation, so it depends on the state what term they use. Some say rules, some say regulations. And so bright line means it's very objective, very clear as to what is required by the law. So for a licensee or a registrant of a board of pharmacy to follow a bright line rule, it would be very easy to figure out what the expectations are. So it's easy for the licensees, it's easy for the board, right? And particularly the board attorneys. So for example, continuing education. You must have 15 hours of continuing education every calendar year. That's an example of a bright line rule. Very easy for a board to determine who's not followed that law. They run a report from NABP's CPE monitor, and they find out how many people don't have 15 hours in the given time frame. And then their board attorney can then prosecute those cases against the people who broke the law, right? State boards of pharmacy have quasi-judicial and quasi-legislative authority. The quasi-legislative authority allows them to establish rules, and the quasi-judicial authority is, I can take your license away if you don't follow the laws, or I can suspend your license, or I can fine you as part of not following the law. So board attorneys really like bright line rules because it makes it really clear that somebody's broken the law. Very easy for a board attorney to prosecute, right? It's very black and white. Pharmacists, like I said, also like things to be really black and white. They're like, please, no ambiguity. Tell me exactly the guidelines to follow, and this is how I will take care of every patient, right? So same with the law. Tell me exactly what I have to do to follow the law, and I will do exactly what you've told me to do. So there's not a lot of judgment, not a lot of thought required with a bright line rule. Now, standard of care is really different. And I want to be sure, too, that I differentiate between standard of care and standards of practice, because those are different as well. So I'll come back to standards of practice, but first I'll give you sort of this idea of what is standard of care. Well, standard of care says that I'm going to provide care to a patient, and it's going to be consistent with what some other practitioner would do in the same situation, right? So I'll give an example that's used in medicine, because medicine and nursing have been regulated in this way always, right? So if I'm a surgeon and I am operating on a patient, and there's fluids, there's blood, and I use sponges to clean that up during the surgery. If I leave a sponge inside the patient and close up that patient, there's a risk for infection. That patient's going to potentially be harmed, right? So do you think that the State Board of Medicine in any of the 50 states has a rule that says if you are operating on a patient, you must remove the sponges before you close the patient?
No.
And whenever I ask people that, they're like, no, that would be ridiculous. Imagine the number of rules that they would have to have, right? So the idea that how do we regulate physicians, right? Like if we can't very specifically tell them what they have to do, how do we regulate that? Well, they're regulated using this idea of standard of care. So if this happens, patient is harmed, it gets reported to the Board of Medicine. The Board of Medicine is then going to come in and they're going to bring 4 or 5 people who are all surgeons in that same part of the state, who have the same education, training, and even experience level, right? We're not going to take a super experienced surgeon versus somebody who's only been practicing independently as a surgeon for 3 years, right? So we're going to bring in people, same education, training, experience, same practice setting, and likely even the same part of the state. We say here in Idaho that practice in the Boise Valley, which is the largest populated part of our state, is really different than Yellow Pine, which has got this many people in it. That practice is different there. So the standard of care is going to be different, even in regions of a single state. So we're going to bring in those 4 or 5 people, and they are going to testify in front of the Board of Medicine, and they are going to say, yeah, this physician did not take the sponges out of the patient. That's not the appropriate standard of care, not what they should have been doing. And the good news is that in this sort of a model, then the Board of Medicine could penalize that physician for the mistake that they made, that surgeon. And if there's a new technology that comes out that we stop using sponges in surgery, there's something else, Board of Medicine doesn't have to go back and change their rules because they had this rule that said you must remove the sponges before closing the patient. So standard of care says that no matter what your clinical ability is, right? So clinical ability is your education, training, and experience, and it's different for every practitioner. Standard of care says that when you regulate in this way, it puts the top of your license at the same level as your clinical ability. So with Brightline, one of the challenges and cons with Brightline is that it creates sort of a false ceiling for what every practitioner can do based on what their license allows. So their scope of practice gives you this very specific ceiling, which is great if everybody's clinical ability matches that ceiling or is above it. But if there's anyone who their clinical ability is below that ceiling, That's a danger zone, right? The mission of every board of pharmacy in the United States includes protecting the public's health and safety. Pretty much every single one says we're going to protect the public's health and safety. If I've created a false ceiling and there are practitioners whose clinical ability does not meet that ceiling, that's a danger zone when it comes to patient safety. And I may or may not be able to prosecute that person unless I can think of every possible way that their clinical ability might not meet that line. And I write something very specific for that, that's very black and white. So it makes it really difficult to manage for those folks who their clinical ability is not at the level that it should be. It's also really difficult for the person whose clinical ability is above that line, right? Not below, but above. There's a portion of time that person whose clinical ability is above that ceiling, that top of your license, that they're bored, right? Because they're like, thinking about this dissonance that we were talking about earlier. They're like, man, I was trained to do all this stuff, but gosh, my license only allows me to do this. And so I never want to be able to practice at the top of my license unless I'm practicing in a state that is regulated using standard of care, because then that means I am practicing exactly at the level of my clinical ability, right? The top of my license is the top of my clinical ability. And that is key for patient safety. So the other piece about this idea of standard of care is that it allows scope of practice advancements without having to write huge protocols into the law, without having to write and think of the worst pharmacists that you can imagine in terms of their clinical ability and all the potential mistakes they might make, and how you're going to restrict any type of scope advancement, whether it's independent prescribing or ordering and interpreting labs, or potentially diagnosing things for a patient, right? Whatever that scope of practice advancement is, it's going to align with their education, training, and experience. So I just use the D word there, right? So that's even bigger than independent pharmacist prescribing, that diagnosis word, right? If you are regulated using a standard of care regulatory model and you diagnose outside your clinical ability, you've broken the law. And the State Board of Pharmacy can then prosecute that case using that standard of care regulatory model. So if we want to be able to advance pharmacist scope of practice in a meaningful way that allows our graduates to practice in the way that they have been trained, we need every single one of the 50 states to adopt a standard of care regulatory model. So there's your solution to problem number one, right? We have to have that standard of care regulatory model to be able to advance that scope of practice so that it's consistent with the education and training. We have 2 states already, Idaho and Alaska, who are regulating using standard of care. And because of that, every pharmacy school now has to educate their students to be able to practice at the level that would be expected in Idaho and Alaska. So that level of dissonance in all other 48 states and 3 territories, right? Or maybe there's more territories that I'm missing. But everybody else that's practicing in those other areas, as our new graduates come out, they're going to experience even more and more dissonance, and they're going to have even less satisfaction. So if we want to destroy the pendulum swing that is starting to go back the other direction, it will be because state boards of pharmacy ignore standard of care. So, we talked a little bit about the safety piece, but the other piece that's important about standard of care for a board of pharmacy is that their responsibility is to protect the public health and safety. Major component of public health is access to care. And if I can't access care because my pharmacist doesn't have the appropriate scope of practice to take care of patients the way they've been trained, then there's no way that I can protect the public's health. So, see, it's a solution for everything, right?
That's kind of what it sounds like you're alluding to, but I think it's very, very important for people to, if you need to pause this, rewind and listen to your explanation again, because it's very important to understand this topic. So standard of care allows for, and similarly, like you had mentioned, to physicians and nurses who have been doing this type for years. This is not something that's, came out of the blue, but it's something that other health professionals are held to. They are held to a standard that other individuals within your profession with the same level of skills, education, etc., would be held to. And I do want to ask you this question, because I believe you mentioned standard of practice, but with a standard of care model, are you holding somebody to their training, education, experience, practice setting? Are you also holding them accountable to the standards within their practice? So is that kind of that missing piece to the puzzle of what does the published literature and their guidelines and all this stuff say? Is that part of the equation with standard of care?
It is. And standards of practice, and thank you for the reminder. See, I knew if I said it, you would remind me. But standards of practice are consistent regardless of who's providing the care. So standards of practice for taking care of a diabetes patient are the same whether you are a PA, a nurse practitioner, a physician, or a pharmacist. There's a certain level of care that's expected. There are guidelines that are expected to be followed. And so standards of practice are important, and standards of practice do feed into this idea of standard of care. But standard of care is focused very specifically on our profession, right? If it's in pharmacy, it's focused on what type of care would a pharmacist provide based on these standards of practice, but based on their education and training, based on their practice setting, right? So it's not something that is going to be consistent necessarily completely with what a nurse practitioner would provide, right? Because a pharmacist's education and training is different than a nurse practitioner's, particularly as it relates to diagnosis. Although I would argue we've been teaching diagnosis for years in pharmacy education, we've just been calling it assessment or advanced assessment. And I'm a big proponent that we need to stop making up words in pharmacy that other parts of healthcare don't use. And we need to be consistent and use the same words that everybody else uses. And so instead of saying that it's assessment and that we never diagnose, we absolutely diagnose. If a patient walks into a community pharmacy and you figure out that you can help them and take care of them with an over-the-counter product, you've made a low-level diagnosis. You've done an assessment, you've talked with them, you've developed a treatment plan, and you're going to give them some education and send them on their way. The pharmacist patient care process does encompass this because we collect information and then we assess, which are major components of the diagnostic process.
Yeah, thanks for clarifying that. I know that that's really important for people to understand too. So there are standards of practice, and all healthcare professionals are held to those standards, but standard of care is zooming in on your profession and what your profession's role would be, within that type of scenario and within those standards of practice. Jen, thanks so much for that explanation. I think that that's one of the critical pieces. And, I'm going to link to the article that you all have published on about this topic. I think it's super important for people to take a look at what this means and what potential comes from this, what kind of issues this type of movement can solve. And I think that it's really important for people to understand the difference between the two, where we've been historically and where we can head in the future. So Jen, we're coming up to a section here that I like to conduct that's really fun. It's a quick session. It's called the hot seat. Basically, how this works is I'm going to ask you 5 questions very quickly. So it's going to be rapid fire. Your goal is to answer with as little words as possible. So 2 to 4, a sentence if needed, but it's meant to be rapid fire. Some of them are going to be a little more serious. Some of them will be a little more fun in terms of the mixture of questions. So Jen, are you ready for the hot seat?
I'm ready as I'm going to be.
All right, here we go. First off, from an Idaho expert, what are the best types of potatoes to make French fries with?
Idaho russets, of course.
All right. Is there an oversaturation of the number of colleges of pharmacy in the United States?
No.
What three things would you have to have if you were stranded on an island?
Ooh, that's a hard one. Water, right? Access to water, access to food, and my family.
All right. Um, is standard of care the future of pharmacy practice?
100% unequivocally, yes.
And lastly, what is your favorite place to vacation?
Ooh, maybe a deserted island where I'm stuck, right? I don't know. I just like to explore. I like to experience various cultures and different things around the world. So don't know that I have a favorite, but when I do want to relax, it's somewhere warm with the beach.
Perfect, Jen. You've been on the hot seat. Thank you so much. So, where can guests find or connect with you if they'd like to follow up or chat, or maybe just follow along with your journey on any websites or social media you have?
So I'm on LinkedIn, Jennifer Athay, Athay Adams. It's got my maiden name in there. Makes me a little easier to find. There's 18 million Jennifer Adams out there. So would love if folks wanted to connect with me on LinkedIn and have some additional chats about this. I'm also on the former Twitter, now X, not super active there, but I am there at JLA Adams.
Awesome. I will definitely link those in the description for people so that they can easily find and connect with you. Last question, Jen. In your journey as a professional, what has been the most significant lesson that you've learned, and what advice would you give to others who aspire to make a positive impact?
Yeah, so I think my answer today is probably different than it would have been 10 years ago, or even, I wouldn't say 5 years ago, but 10 years ago, 15 years ago, easily. And I would say that the most significant lesson I have learned is that I need to listen to what others are saying, to understand what they're saying, to really hear where they're coming from, even if I disagree with them. There are going to be people who listen to this podcast and they are going to disagree with some of the things that I've said. But I'm hopeful that they will spend some time trying to really understand, to see, can that piece of information change my mind? And that it's okay for me to change my mind when I learn new information, right? And that's the hallmark of intelligence, right? If I learn new information, I allow it to shape my opinions, shape my perspectives, because I've learned new information. I understand that now, and I'm going to change my mind, and I'm going to be okay with that. When I was a student, I was part of a group of students who advocated very strongly against increasing the ratio of pharmacy technicians per pharmacist in the state of Idaho. And we were very proud of our accomplishments, that there was some regulation that didn't happen because we lobbied hard against it as students. And today, I would never lobby against something like that, right? I've learned new information. I understand now what it means to have a ratio and not to have a ratio in a pharmacy. And I have a much more complete picture of what that means within the pharmacy industry, right? Like, what does that mean for employers? What does that mean for pharmacists? What does that mean for me to be able to practice at the top of my education and training? Well, it's to have appropriate support staff. And things like ratios are limits on that. Ratios limit innovation. But when I was a student, I didn't understand that. And I was influenced by the opinions of others and went down this path. And so that's probably the most significant lesson that I've learned. Not just that it's not a good idea to have a ratio, but that I need to listen and really understand all the nuance and all the different perspectives before I can say this is the absolute best way to move forward. That I have to consider all of those perspectives and not make it an us versus them conversation, that we're all going to listen to each other. We're all going to try to understand each other, and we're going to solve some of these complex problems, right? We are going to solve the problem of making sure that we have advanced scope of practice if we listen to each other, right? So we are going to solve the problems related to pharmacist payment for services, but we have to listen to each other and understand all of the perspectives, and we have to be willing to change our minds. So that's the most significant lesson I've learned. And my advice would just be to do that. Listen to understand, and don't be afraid to change your mind.
Thanks, Jen. I think that that's very, very wise advice, and I'm glad that you were able to share some color from your life of, how that's impacted you. And I would totally agree. Listening to understand and making sure that we're always learning. And even if you disagree with people, you can, look at different perspectives and learn. So thank you very much for sharing that. Jen, it's been a pleasure. I really appreciate you coming on. You've officially been RxPOSED. Thank you.
Thank you.